This was the picture actually taken during the cardiovascular reversal, and actual temperature of cardiovascular was 60 degrees. But in this picture, you can see temperature is at 20 degrees. This picture shows the little bed after the vacuum. These two pictures actually shows the tumor being extracted from the right atrium. The view is from the anterior side, and the yellow arrow shows the foot development. So the tumor develops from extracted during water. This is a brief video. Yellow arrow shows the anterior side, video being filmed from the head side. This is the atrium open. Such is the atrium manager. In shortly, we can see the developing this is the we also said
ऐसे बंदे हो जाना लाइट चल उसको चलता रहने दे मिनट आ गया साइलेंट क्यों है ये आवाज आ रही है इसमें
these are the categories. This one is the one. So the tumor from the right atrium and the IDC and the category is one by two.
थ्रोम्बस एक्सीडेंट थ्रोम्बस फॉर्म बैठे हैं हाँ राइट एट्रियम
Then the IDC was flushed and closed. So the total operating time was 6 hours, and the screening setting time was 4 hours, 2 hours was for the cardiology, and the estimated blood loss was 2.5 liters, and there is a single complication related to which is paralytic, and post-operative patients stay in ICU for 5 days, and then step down to the ward for 4 days and start again. And the follow-up was given after 2 weeks to discuss the histology, and the histology was PE3 and R1 is the section. Subtype was BSL class 1, Lipovich is 9, and even being margins are expected to perform. So we gave Lipovich highest follow-up to the patient, and at 3 and 6 months, the class and CT scale was held, and it showed no difference. So briefly, we will discuss these PLI. There were total 21 cases in last 2 years, and 17 were made. Hematuria was the most common presentation, and 80% of the patients presented earlier in the disease course. And 19 cases out of 21 with level 3 tumors, level 3 or below. So the only 5 patients diagnosed incidentally, otherwise they had some sort of symptoms. The mean tumor size was like 10 centimeters, and more tumor on the left side and the other. All 5 patients were diabetic and hypertensive, while 2 patients were smoker. Although there was no paralysis syndrome in our patient, but 2 patients stopped taking their anti-diabetic and producing drugs after the removal of tumor and the symptoms. No curative complications were reported in our series. Subabatic IVC with venous were performed in 2 cases and medical effective in 14 cases and medical effective in IVC submetal was performed in 7 cases, including the liver category surgeons. Control level PD was monitored and followed, and we reviewed 9.5% of cases with tumor weakness and managed with admin therapy. So average operating time was 196 minutes, and there was no post-operative complications in the last 10 days. And in our series 1.1 and the post-operative it rose to 1.5 milligram per deciliter. The mean hospital stay was 7 days and the ICU stay was 1.8 days. And the nuclear polymorphism and the lymphovascular healing were positive in 3 and 12 patients respectively, and the sarcoma features in 1 patient. The mean ISP was 3 and the mean leukoid score was 6, and negociable are present at different levels in our series. The average follow-up was given to the patient. They followed 3 monthly to us. The tumor recurrence was found in 2 patients, and they were given referred to the medical oncology and managed therapy. So these are the CT scans of 3 patients. As you can see, the red arrow shows the tumor, and the green arrow shows the tumor tremors in the IVC. And reflected to the left side, this is the supra right on the IVC. These are the this picture is actually had in this lamp pure. These are some pictures of tumor extension, which they extracted and how they came to. So coming to deep literature, we ICC tumor centers is associated with brain tumor, RCC, and adenocarcinoma and hepatocellular carcinoma. And they can be symptomatic and they sometimes present with radical symptoms like varicose and edema and polyembolism or Bardet syndrome. We usually classify it according to the weight classification and PNL classification. As you can see, the human service factor due classification, human service in the weight is level 0, within 2 centimeters level 1. Service very complication is 78% and mortality is 13%. 5 cancers, specific survival, resection and 7.4% distant. 26% 5 cancer specific survival is when the patient is directly got the 57% improved with the gamma is you perform the factory, can we just mobilize the kidney and then we go back in the agreement and later on we perform the factory? So we assess we did the responsibility, so we can assess kidney, whether the factory can be done or not. Then the whole team, the cardiovascular, we a giant venture, and we will always get the factory and the cardiovascular surgeon and remove the equipment from the patient. So you were only thinking that it was just easy to ease off the tumor or was infiltrating the walls also? In this case, it was not infiltrating the walls. It was not that easy to remove off the tumor. But
in the level 3 cases, we actually don't prefer doing nephrectomy upfront. But in level 4, because the thrombus is actually snugly fed in this particular case, and we don't have any doubt that it's going to migrate. And upfront nephrectomy doing level 4 cases is rather easy to do the nephrectomy first and then put the patient on cardiopulmonary bypass so that we can omit the bleeding part and remove the thrombus. In this particular case, the challenge was to remove the thrombus expansion that was into the right pattern vein, which was a difficult part. The thrombus was very much as density and there was less vasculation around the paper. So we removed the infra abdominal part very easily. But and by opening the right atrium, we removed the atrial part, but the right atropine part was then visualized through the right atrium very easily, and then we just removed it in charts and did the work there.
What was the presentation of this case? As you said that he presented with hematuria.
Yes.
But there was a Thomas right atrium. What about breathlessness?
What about
About dyspnea on the organs?
This case was actually referred to us in had 20 years.
Because with this one of Thomas right atrium, the patient presented with breathlessness, dyspnea, and palpitation. But you said that it was only hematuria in this case.
Actually, what was the most common presentation in our case is our second case. Then we present talking about Abdullah, that is association and road dissection. Dr. Abdullah.
Very likely.
Now, we can discuss critical classic AC. There is conflict of interest. So this is the first case series from RPMD in Pakistan. Obviously, there has been case reports before, but this is one of the first case series with a contemporary literature review. It has been published in Journal of the Human Resources Afterward. So, coming to the abstract, recommendation is for dissection techniques and integral part management and study clinical users in men and the frequently performed. The purpose of the study was to review the clinical outcomes and complications of RPMD. It was conducted at Pakistan Medical Institute, Lahore, for a duration of 2 years. It was a retrospective case series and patient demographics, medical history, surgical details, post-operative course, and followed with a solid structured questionnaire. There were a total number of 5 patients with an average age of 30 years. They had an average length of stay in surgery of 256 minutes, which is about 4.2 hours. There was one complication requiring blood transfusion. Comparing the laboratory parameters of the patients with the normal values, we saw a significant drop in beta FCG levels pre and post ovulatory. Highlighted. The total duration of surgery was about 256 minutes, which was 4.2 hours. The size of the lymph node dissected out were approximately 8.5 centimeters. Estimated blood loss was about 480 mm. The histopathology specimen size was also reported about 8 to 9 centimeters. The duration of ICU stay was 2.4 days. The length of total hospital stay was 7.2 days as well. The urinary catheter was removed after about 3 days, and the drain was removed in about 10 days. The pathology of these 5 patients showed 2 cases of teratoma, 1 case of cystic teratoma.
one case of mixed genital tumor and one column tumor. Here we have an image complex case. Here you can see there is large endometrial mass which is encasing the left ureter as well. This is the dissection that we perform. So here you see this is the pre-dissection image before performing the lymph node dissection into the aorta. So aorta, vena cava, here we have the right ureter, and these are the common iliac vessels. Here the lymph nodes have been dissected out. You can see the aorta, the vena cava, the iliac vessels coming down here, and the right ureter. So we perform RPLD and we improve ureteroscopy in this case. This is the post RPLD scan of the patient. As you can see, there is some reactionary cases and fluid infusion. The lymph nodes have been cleared from here. So, coming to the literature review, I'll just go through the main points of this literature review. The key outcomes were that we had a very good survival rate, which is about 90% in these cases. These are studies from high-end centers where there is a number of cases of RPLD and had high ICU care. And we have two literatures coming to the recent surgeries, which include robotic and laparoscopic surgeries of RPLD. They showed that the robotic RPLD had low blood loss compared to open surgeries. There was a short hospital stay, and the recurrence rate of robotic RPLD versus open RPLD was better, 10% and 16%. So robotic RPLD can be this alternative with post-patient selection. Brief overview of RPLD. Indication non-seminal germs and tumors with blood loss and the main dialysis or formation, liver formation. The patients typically counsel about stomach vacuum or chemotherapy and the issues of infertility should be discussed with the patient. They can be has dysfunction ejaculation after the procedure. This should be discussed with the patient before the procedure. And we should take a biopsy from the live tissue to establish that the metastasis is functional. Psychology diagnosis to the patients and diagnosis as well. This is the template for RPLD. As you can see, the upper level is the lower level of the left uterine. And the left side is the uterus. And down below, the point where the uterus cross the common iliac vessels. This is the region where all the lymph nodes have to be dissected out. Thank you. We still have to follow patients for ED and rectal dysfunction in these cases. It takes time to recover.
In which cases you would write for sperm banking? Sperm banking. In all cases or in specific cases?
In all cases.
And where do you send this sample for sperm banking? In DK or some private lab?
We don't have the facility at DK lab, so we refer the patient out to the hospital to offer sperm banking.
Sir, these particular patients were actually referred specifically for RPLD. These were post-operative, post-web therapy, and these were just particularly referred only for RBI. The procedure of sperm banking or other stuff about the counseling that was already being done outside. These were all post-op negligence and all post-chemotherapy. The word was.
But in all cases, you send this form for banking or in specific cases?
So, sir, as I already mentioned,
जैसे कि ये एक साइड का ट्यूमर दूसरे टेस्ट से ठीक है इसका लेकिन आपने इस फॉर्म बैंकिंग तमाम केसेस में या पीछे से होके आई थी या आपने रिकमेंड की
सर हमने इनको रिकमेंड नहीं की ये हमारी वैसे प्री ऑपरेटिव चेकलिस्ट है फॉर आरपी इवेंट्स बट जैसा मैंने बताया इनमें से कोई भी केस ऐसा नहीं है जो अपफ्रंट हमारे पास आया हो और उसको हम टोटल कोर्स ऑफ ट्रीटमेंट में लेके चले इसको सर ऐसा है कि पेशेंट पूछा जाता है अगर उसमें फैमिली को ठीक हो अगर वो टेक फॉर द प्रोसीडिंग्स तो उससे उसको डॉक्यूमेंट करवा दिया जाता है और उसके बाद फिर अगर तो उसकी एंटिसिपेशन हो हैव द फैमिली फिर उसको किया जाता है अदरवाइज भी क्योंकि एक्सपेंसिव प्रोसीजर है फिर बहुत थोड़े उसमें ये हर केस में नहीं एज अ रूल इसलिए जहाँ पर फैमिली को ठीक है मतलब जरूरत नहीं है फैमिली नहीं है और एंटिसिपेट कर उससे पहले डॉक्टर करते हैं सस्पेंड कर देते हैं And sir, Professor Hafiz Salasa about erectile dysfunction. So we haven't faced any erectile dysfunction in these cases, but obviously, as we have taken out the sympathetic chain in these cases, all the cases were advanced and all were non-nerve sparing RPA. So we faced issues about the ejaculation, but there was no issue regarding the ED that was particularly faced in these cases.
सर आपने कहाँ से कराया वो इंटरवेंशन देख का कराया
Thank you, Dr. Abdullah. The third case is and the presenter is Asif.
अच्छा गा रहा है चूँकि वो बेसिस नर्सेस को वो भी काम कर रहे हैं क्यों मेरे पे वो बोल पार्ट करना चाहिए हाँ अगर वो क्या करेंगे समझिए को बात करना प्राइवेट से भी नहीं वो कर सकते
Study of 53 gentlemen who presented with the complaint of black man pain. So the title of this study was a comprehensive case study of the man with hepatitis C, nephrectomy and multifactorial patient. There are no matter of interest and sleep. So I will start with a 53 gentleman in one case of diabetes, hepatitis C. He presented was complaint of black man pain, otherwise 3 times therapy. On the other workup is the use index suprarenal lab. In CT scan with the large lab suprarenal lab 20 centimeters and liver fluid rotation quality in spinal substances not catalyzed hypodynamic. Here in CT scan of the patient we use left suprarenal lab and left facing left suprarenal. So this case was discovery for anatomy and our family has that great for left policy of our left left policy and left policy that was directly of the hand and Europe.
potentially
If any of the knowledge work are done, so non-complete adrenal and liver did not discuss the cirrhotic liver, and they decided liver transplant is the best option for this. And Urology can proceed for that. So, according to our plan and our activity decision, we have
Big Bamba.
left radical retinal activity. So, the procedure was and what due to large mass and surrounding vessels, our team had decided to convert lab into open radical retinal activity. So we have to participate into lab with open radical retinal activity and respectively. The intraoperative finding was lab retinal mat, contrasting lab being downward, nasty, adjacent to the law, retinal explaining vessels surrounding this. So post-operative course was suitable post-operative course on more active selection and therapy management. On follow patient histopathology shows metastatic well radiated hepatocellular carcinoma grade 1. Urinary and vascular multiplication. So on follow for surgical complications, stable post-operative course. So we refer this patient to liver OPD for unsuspected histopathology. So liver decided for this patient multiparametric MRI Roman, especially on liver protocol, which show high-grade dysplastic in segment 7 and 8, no SCC and bad chronic liver disease. This is a picture of multiparametric MRI. The arrow shows the dysplastic reduced at dimension of segment 7 and 8. After multiparametric MRI, liver team deciding for systemic chemotherapy, and for that they refer into oncology. So the global impact of hepatitis C virus invaded our chronic liver disease, and it is associated with the fact of fatigue manifestation. And the unique aspect of this case was the rare link between hepatitis C virus and adrenal tuberculosis. The origin of this case, metastatic hepatocellular carcinoma in the adrenal gland is very rare, affecting multidisciplinary management is provided for this case, and thyroid unique HCV associated complications. Thanks to medical and surgical team and patients for presenting this case. Thank you.
Well, your presentation, mashallah. There is one question that in your CT scan on the common image there was compression of the left kidney, but there was no actual images. What was the need of doing nephrectomy in this case? When you said in the margin of the ureteral artery, but you didn't comment on the kidney, adrenal gland showing a pattern of SCC. So what was the need of doing nephrectomy in this case?
Due to large mass and to mass we
Sir, I was one of the surgeons involved in this case. We started in lab. The plan was to save the kidney, but the dysplastic direction around the renal mass was too much that upper port was not separable from lab. So the actual aim or the conversion reason was because of the neovascularization, and also by doing open we could save the kidney. But the renal vein and the splenic vein both were just densely adherent to the renal mass, and kidney has to be sacrificed rather to achieve the treatment levels. Otherwise, we will not be able to achieve a clear margin in this case.
When the space was this how you able to spare this pancreas?
Pancreas, so as we all know that the splenic vein has got an inferior relation to the pancreatic vein. So separating it was not that much an issue regarding to spare the spleen. But pancreas was easily separate from this mass, as in the
Excuse me. How can you, excuse me, also, how can you correlate that this is have three virus infection is due to adrenal carcinoma? Was it already in principle? In Pakistan, this is the first case that I reported about. Question is, it can be coincidental finding if we have lot of patients with Hep C virus, we have Hep B, CHA, common in our community. How can you say that Hep C virus is the causative factor for adrenal adenoma? It can be incidental.
I can answer this question. Actually, as you all know, that he had a cirrhotic liver previously, and it was hepatitis C, and you know that cirrhosis is associated with hepatitis C associated with HCC, very much common. Then, in this particular case, as we mentioned that it was through the liver MDT and our MDT, and it was a unanimous decision to take, if we just look back into the MRI image, this person module was in the segment 7 and segment 6, and the patient was already sorted. In these particular cases, if supposedly it was an HCC, the resection of the liver is not that much easy. Patient may get a free margin by doing a total right hepatectomy. And in these cases, which are already cirrhotic, achieving the right hepatectomy causes the patient to have a small for size issue from the liver aspect.
Also, I think I am not putting my point. I'm can you establish the relationship that Hep C virus infection with adrenal adenoma as what previous report suggests? Yes, hepatitis was also associated with hyperaldosteronism. Due to hyperaldosteronism, this case was also missed. What is histopathology is very typical metastatic hepatocellular carcinoma. On follow-up, we have searched of that multipathologic MRI done which show this blocking that cell. Okay, Dr. Sandal, I have another question from the previous case report. Where there was all the patients with RPFND were discharged on the average of 7 post-operative days, and the drains were removed on the 10th post-operative day. Was there any specific reason to remove the drain on 10th post-operative day? Was the drain heavy?
There was an average collected data. One of the patients had a drain for almost 21 days post RPND. In RPND cases, we try to ligate our gold template with the Liga clefts because the post-operative leakage of lymph is very common in these particular cases. One patient had to have a drain for a long time. As shown in that picture of the template, we just dissect through the template, that is the left renal vein, superiorly and common artery inferiorly and both the ureter. We, after dissecting or taking out the whole nodal mass, we clip that margins so that in order to prevent from the lymph leakage. But still, some of the patients may get lymph leakage. In this particular case, that was presented with a huge mass. That patient had a drain for almost 21 days because he had a massive mass and there was densely irregular aorta. And for the post-visual element, I want to mention one thing. In RPLND, normally that section is started from the common iliac artery because starting it with the vein or with the pre-cable part was actually quite dangerous. Aorta and the arterial structures are dense, or have a good strength. So the tissue dissection is quite easy, doing it from the arterial structures rather than starting it from the cable part.
The last question, please. It was also mentioned that the contralateral testing was biopsy quantification was considered regarding that. What cases if there was contralateral test is totally fine, would you still advise the patient to get biopsy of the contralateral test?
Yeah, whatever do it.
Thank you.
Thank you, Dr. Nathik and Dr. Satun, for nice case presentation. Our last case is robotic case series by Dr. Shah.
So there is no concept of interest in stories, and the discussion includes commercial issues, technology, contextual in Pakistan, and audits of